Today we are going to discuss about disease included in the nephrotic syndrome known as focal segmental glomerulosclerosis. And when we talk about FSGS, it is the most common type of nephrotic syndrome in adults. Okay, so it is most common in adults. Let's talk about the etiology, the causes, why the FSGS happens, right? So first of all, there is a primary cause and there is a secondary cause. Eventually, the primary cause includes idiopathic. Most of the nephrotic syndrome that when we discuss about etiology, their primary cause will be idiopathic. In some of the diseases, there can be a genetic mutation in the genes or proteins, right? When we talk about the secondary cause of FSGS, there is a bunch of infections, drugs, and other anemia conditions. So first of all, let's talk about it. In the secondary cause of FSGS, first of all, it is more common in Hispanics. Hispanics are the people who speak Spanish, right? Hispanics are African Americans and Black people. These are very susceptible to the development of FSGS and also the obese patients. The second important condition that can lead to FSGS is human immunodeficiency virus, that is HIV, and when this virus causes HIV, we term it as HIV associated nephrotic syndrome. So the whole term means human immunodeficiency virus associated nephrotic syndrome or nephropathy. Done. The next virus is hepatitis B virus. Hepatitis C can be included, but it's related to other nephrotic diseases. Here, hepatitis B holds a very specific position. Hepatitis B virus. You know that hepatitis infect the liver, right? So, why there is development of renal disorder? It's extrahepatic manifestation of hepatitis B. Extrahepatic manifestation means that it is affecting the kidney, that is extrahepatic. The next virus is human parvovirus B19. Okay, it is also can be included in the cause that in the secondary cause that lead to FSGS. I will talk few sentences about human parvovirus B19 because it is also found to cause pediatrics infections. So pediatrics, there is a very classic slapped cheek appearance. Slapped cheek appearance in the pediatrics or children that is associated with human parvovirus. The second thing human parvovirus can lead to is known as erythema infectiosum. Okay, infectiosum. Human parvovirus can also lead to that. The third condition is known as aplastic crisis. These all are included under the heading of human parvovirus. Aplastic crisis. And what is aplastic crisis? There is sickle cell anemia plus hereditary schistocytosis. Okay, hereditary spherocytosis. I will repeat again. Aplastic crisis includes sickle cell anemia and hereditary spherocytosis. So what is the next condition that can lead to FSGS? As I've told you, drug abuse like heroin, lithium, or bisphosphonate. Bisphosphonate is a very large group of drugs, and in the bisphosphonate there is a specific drug known as pamidronate. Pamidronate, lithium, heroin, these all can also lead to FSGS because their toxicity is very dangerous to the renal system. The next disease is known as vesico-urethral reflux disease, i.e. we can also call it as reflux nephropathy. Reflux nephropathy. It is also included in the secondary cause. So vesico-urethral reflux disease. Second, one of the most important hereditary condition known as Alport syndrome. In Alport syndrome, there is congenital or hereditary defect or deficiency of type 4 collagen. It's type 4 collagen deficiency or defect, and it can affect eyes, right? It can also affect ear, and it can affect the kidneys. In the eyes, it leads to anterior lenticonus. I'm not writing that. Anterior lenticonus. In ear, it can lead to sensory neural hearing loss. And in the kidney, the topic for today is FSGS. That's what it causes, right? The next condition is sickle cell anemia itself, right? One of the complication of aplastic crisis is sickle cell anemia, but sickle cell anemia itself is very notorious to cause FSGS. In sickle cell anemia, the RBCs are sickle in shaped, okay? They are sickle in shaped like this. So it causes the vaso-occlusion in the medulla of the kidney. Vaso-occlusion in the medulla. Vaso-occlusion in the medulla. So when the medulla is vaso-occluded, can the kidney concentrate the urine? No. It leads to a condition known as isosthenuria. Isosthenuria. Isosthenuria is a condition. It is defined as inability of the kidney to concentrate the urine because of the sickle-shaped RBCs that have blocked the vessels, the vasa recta more specifically, that loops down into the medulla that is involved in the concentration of the urine. When these vessels are occluded, the urine cannot be concentrated. So let's talk about the clinical findings or clinical features of FSGS. Clinically, the symptoms is similar to the nephrotic syndrome that we have discussed in the previous lecture, because eventually it's also a nephrotic syndrome. So first of all, there will be nephrotic range proteinuria, that is more than 3.5 grams of protein per day in the urine, right? More than 3.5 grams per day. The next thing is the edema. Why edema is happening? Because there is selective proteinuria, that is albuminuria. Albumin that is very helpful in maintaining the oncotic pressure is lost in the urine. Eventually, there will be low oncotic pressure in the blood, and this leads to edema, right? This leads to edema. The fluid will shift from the circulation into the tissue space, that is edema. And in the morning there will be periorbital edema, in the mid of the day there will be genital edema, and at the evening or at the night the patient will complain of pedal edema, that is edema in the feet, right? The next thing is that low GFR. Because there is edema, so there will be less fluid in the blood circulation, so it will activate the RAS. Edema will cause low GFR, and low GFR will activate the RAS, renin-angiotensin-aldosterone system, and this RAS will activate aldosterone. And aldosterone will cause increased sodium and water reabsorption in the distal part of the nephron. Aldosterone will cause sodium plus water reabsorption in the DCT, distal convoluted tubule. So it will eventually leads to hypertension, that is known as the high renin hypertension. It leads to hypertension because water and sodium, they will increase the blood volume, that leads to hypertension. The next complication that we see clinically is known as uremia. In 50% of the cases of FSGS, in 50% of the cases in next 6 to 8 years, right, we will see symptoms of uremia. Why uremia is happening? Because the patient's kidney is unable to excrete urea into the urine. That's why urea starts to build up in the blood. That's what we call uremia. And uremia is very dangerous for the system. It leads to uremic pericarditis, and uremic encephalitis. These are two conditions that uremia can lead to encephalitis, right? One more thing that we can find in case of uremia is the uremic frost. What is uremic frost? When urea starts to leave via the sweat, because kidneys are not excreting it, so it has to find another way to remove from the blood or the body. When it leaves via the sweat, it evaporates and leave behind yellow whitish crystals on the skin that we called as the uremic frost. Okay, that was for clinical features. So what is the investigation or workup for such patients? Investigation or workup, what we can do in such conditions. First of all, we will check the kidney function test. Kidney function test, KFT, will obviously be deranged. Deranged means that serum creatinine in serum will be high. That's exactly what KFT derangement indicates. KFT derangement, serum creatinine will be high. The next is that in urine microscopy, microscopic examination of the urine will reveal hematuria. But this hematuria, is it macroscopic or microscopic hematuria? It's microscopic hematuria. Because in nephrotic syndrome, there is no glomerular basement membrane damage. It's only the podocytopathy. So in case of podocyte damage, there is no significant hematuria. We call it as microscopic hematuria. What is the definition? More than 3 RBCs per high power field. This what we call as microscopic hematuria. More than 3 RBCs per high power field. Done. On light microscope, when we see the urine specimen, we can see, first of all, for the light microscope and electron microscope, we need to do the kidney biopsy. We will extract a biopsy sample from the kidney more specifically at corticomedullary junction. There is a junction between the cortex and the medulla, and we insert a needle, very fine needle, and then we take a tissue sample from here. But how we know that we are reaching the exact point? It is by the ultrasound that we called as ultrasound guided kidney biopsy. And when we put that sample under light microscope, we can see sclerosis and halitosis. Sclerosis plus halitosis. The name itself suggests that the focal segmental glomerulosclerosis. It means that there will be glomerular sclerosis and halitosis. What is hyaline? Hyaline is eosinophilic, very dense kind of structure that we see under H&E stain in light microscopy. We call that hyaline. And is it focal or it is global? Focal means that less than 50% of glomeruli are involved. Less than 50% of glomeruli are involved. And the glomeruli that are involved, are they fully involved or only their segment is involved? Focal segmental glomerulosclerosis means that only a part of that glomerular segment is involved in sclerosis. Other finding in the light microscope, there will be normocellular glomeruli. There will be normocellularity. There will not be hypercellularity. Okay, the tubules and the lumen will be absolutely normal, because this condition is only affecting the capillaries. It is not affecting the like parenchyma, the mesenterium, the tubules, the lumen. Okay, there will be only capillary tuft, that is called glomeruli, that is affected. So we can see obliteration of glomerular tuft. Obliteration of glomerular tuft is seen in FSGS. What kind of obliteration is exactly there? It is the hyaline material that is deposited there, right? So when we see the specimen under electron microscope, we will see a very classic, very important finding or detail that we know as podocyte effacement. Podocyte effacement. Podocytes are actually the food processes that we also call as visceral epithelium, right? So podocytes are normally like this. They have food processes, tiny food processes. In between the food processes, there is filtration slit. But if there is effacement that leads to destroy or thinning of the food processes, the podocytes will be like this. So it is affecting the filtration, because podocytes are not able to hinder or restrict the filtration. So the albuminuria, proteinuria, lipiduria will be there. Podocyte effacement. But this finding, podocyte effacement, is also very clinically important in minimal change disease. Minimal change disease affect mostly in pediatrics, in children. So what is the difference? In the exam, when you see podocyte effacement, you can think of both FSGS and minimal change disease. But what is the difference? We need to see the age of the patient first of all, and if the word podocyte vacuolization or detachment is written, podocyte vacuolization or detachment is written, it is very specific to FSGS. So here we can find the difference between minimal change disease and FSGS. The other workup we can do apart from light microscopy, kidney biopsy, urine microscopy, electron microscopy, there is infection panel. We can set an infection panel to see whether there is hepatitis B virus, whether there is hepatitis C virus or HIV or human parvovirus. So infection panel is very important to rule out that conditions. The next condition, we can have an autoimmune panel. Autoimmune panel. But why we need autoimmune panel? There is a condition known as lupus nephritis. The condition known as systemic lupus erythematosus that leads to lupus nephritis. It is an autoimmune condition. So to rule out SLE, we need to do autoimmune panel. The next thing is that urine toxicology screening. In urine toxicology screening, we need to look at heroin. Either there are traces of heroin, either there are traces of lithium, either there are traces of pamidrone, that is drug abuse. So urine toxicology is important for that. Also, we can do ultrasonography, right? In case of ultrasound, we are going to find enlarged, bilaterally enlarged kidneys. They are bilateral enlarged kidneys. But bilateral enlarged kidneys are not specific to FSGS. It is also present in case of polycystic kidney disease. Polycystic kidney disease, both in autosomal dominant and recessive. The next condition in which bilateral enlarged kidneys can be found is hydronephrosis. So ultrasound is not very peculiar to the FSGS, but here is the thing, bilateral enlarged kidneys under the ultrasonography. So it can be important or it cannot be because there are other conditions related to that. Let's talk about the treatment aspect of the FSGS. First of all, in case of secondary, we need to treat the cause. We need to treat the cause that is causing the FSGS, because secondary there is there is infections, there is drug abuse, there is sickle cell anemia, there can be like aplastic crisis, heroin abuse. So we need to treat that particular cause. But in case of primary, we have a very important list of drugs that can help to reduce the clinical symptoms. First of all, for hypertension, because as I've said that due to low GFR, renin system will be activated, it leads to high hypertension, high renin hypertension. So for hypertension, we can give ACE inhibitors, angiotensin converting enzyme inhibitors, and ARBs, angiotensin receptor blockers. These both will cause decreased aldosterone because it is inhibitor of angiotensin converting enzyme and it's angiotensin receptor blocker. It means that in both of these drugs, aldosterone will be deficient. They will inhibit the aldosterone production. And the most important function of aldosterone is to reabsorb sodium and water in the DCT. When aldosterone is inhibited, can sodium and water be reabsorbed? No. So it will automatically treat the hypertension. But there is a price we have to pay for this if we use these two drugs in combination. If we use ACE inhibitors like captopril, enalapril, lisinopril, and angiotensin receptor blockers combined, it can lead to hyperkalemia. Hyperkalemia because when sodium and water are being reabsorbed, there is excretion of hydrogen and potassium, but they are not being reabsorbed, so they will not be excreted as well, and they will be built up of potassium in the blood. So that's why either of the two can be used. Either we can use angiotensin receptor blockers or we can use ACE inhibitors. The next thing is edema. For edema, we can use thiazide. Okay, like hydrochlorothiazide, chlorthalidone, right? So thiazides can be used for the edema. But if the edema is refractory in nature, refractory edema. For refractory edema, we can use furosemide, that is a loop diuretic. Furosemide plus metolazone. Metolazone is a type of diuretic, right? So furosemide and metolazone can be used in case of refractory edema. But the furosemide, the thiazide, metolazone, they will cause potassium loss. Potassium loss into the urine. When we are treating the edema, automatically there will be loss of potassium because these drugs, the loop diuretic, the thiazide diuretics, these all are potassium wasting diuretics. Do we need such hypokalemia in a patient of FSGS? No. When we have treated edema, we need to look for spironolactone. And spironolactone will help to treat hypokalemia component because spironolactone is potassium sparing diuretic. It's potassium sparing. It means that it will inhibit the loss of potassium into the urine. It will inhibit the kaliuria. Okay. Last, the proteinuria. For proteinuria, we cannot stop it, but we can handle it. For proteinuria, we can give steroids and immunosuppressant drugs like cyclosporine. Okay, cyclosporines or cyclophosphamide, these are immunosuppressants. They will inhibit our immune system, but they are also very helpful in treating the proteinuria component, right? And last but not the least is salt restricted diet. We will recommend the patient to not have enough salt in the diet. Salt restriction is very important because this salt will lead to hypertension and it can also lead to edema. So that what we have treated, we do not want it to happen again. So this is for the FSGS. One more thing, when we have done the light microscopy and electron microscopy, can we also do the immunofluorescence? Yes, we can do it. Immunofluorescence is a technique that indicates the deposition of immune complex or immunoglobulins. But in case of FSGS, most of the cases, the immunofluorescence is negative because there is no specific deposition of immune complex in the glomeruli. But in some conditions, there can be non-specific deposition of IgM. It is the immunoglobulin C3 and C1. These are complement proteins, right? So in some conditions, there can be non-specifically deposition of IgM and C3, C1. Okay. Lastly, we need to talk about Columbian classification and we will look at these slides. What is Columbian classification of FSGS? Columbian classification has divided the FSGS into 5 types. Okay. Number 1 is FSGS NOS. FSGS NOS, it is not otherwise specified. It is the most common type. The second is FSGS glomerular tip. Okay, FSGS glomerular tip. The next one is FSGS glomerular collapsing. FSGS glomerular collapsing type. The fourth one is perihilar type of FSGS, and the last is the cellular type. Okay, this is the Columbian classification, just for an extra edge. We need to look at these microscopic slides. Okay, in this condition, it is light microscopy, and we can see the circled area in which there is halitosis and sclerosis happening in the glomerular tuft. This pink material, the eosinophilic material, is hyaline, and it is deposited in FSGS condition in glomeruli. Also in electron microscopy, we can see podocyte effacement. Podocytes have lost their food processes. Okay, that what we call as podocyte effacement. Okay, so this was for today, and